Good morning, good afternoon, and good evening, wherever you're joining us from today. It really means so much to see families, clinicians, and advocates coming together from all over the world. Welcome to today's session in our educational webinar series. Relapse is one of the hardest words a family affected by neuroblastoma can hear. Given the statistics, some parents find themselves quickly preparing for the possibility from the very beginning, while others do everything they can not to think about it at all. Both responses are human and both coming from the same place: love, fear, and hope that this will never happen to their reality. When relapse does occur, it often comes after months or years of intense treatments, hope and endurance, and it brings with it uncertainty, fear, and incredible difficult decisions. For parents and caregivers, this moment can feel overwhelming and isolating, but today's conversation is about clarity, knowledge, and progress. It is also part of the broader global effort to stand together as a community. Around International Neuroblastoma Awareness Day, we launched the Neuroblastoma Day Pledge, which continues to grow. And already many nurses, parents, researchers, oncologists, and supporters from all over the world have taken part. When you see these pledges coming in from different countries and continents, one thing becomes clear. Neuroblastoma is universal. No matter where a family lives, they are not alone, and neither in this fight. We invite everyone who hasn't yet done so to join us, take the pledge, and help us keep building the visible, united global community. We are honored to welcome Dr. Daniel Morgenstern from the Hospital for Sick Children in Toronto. Dr. Morgenstern brings a uniquely broad perspective to this conversation, working at the intersection of clinical care and international research. Through those collaboration with global researchers group, including investigators from COG, NANT, and SIOPEN, his work helps to bridge approaches across North America and Europe with shared goal to improving outcomes for children facing neuroblastoma. Today, Dr. Morgenstern will help us better understand that relapse means what relapse means, how the treatment landscape evolving, and how research and clinical trials are shaping new options and new hope. For families, this knowledge is not just academic. It is empowering and helps us navigate this journey. Dr. Morgenstern, thank you so much for being here today and for your dedication to children and families around the world. We're truly grateful to learn from you today.
Thanks so much, and thanks so much everyone for joining. So let me just take a second to share my slides, and then we'll get started. Hopefully they're sharing now. Okay, so this is a quick word about me and who I am. So as you've just heard, I'm an oncologist at Sick Kids in Toronto. I actually originally trained in the UK and then moved to Canada in 2016. And now I co-lead the neuroblastoma service here at Sick Kids in Toronto, amongst other things. A brief word about the hospital. So I'm located in Toronto, which is the largest city in Canada, and Sick Kids itself is the largest pediatrics, so the largest children's hospital in Canada. And as we never get tired of saying, was awarded the world's best specialized children's hospital award from Newsweek just very recently. We have a very big cancer program, including bone marrow transplant, cellular therapies, MIBG therapy, and extensive clinical trial program. And we get about one new diagnosis a day, so it's around 360 a year. So we're quite a large center. And so what I want to talk about today is relapse, specifically focusing on relapse of high-risk neuroblastoma. And really, rather than getting into the nitty-gritty details of individual treatments, although we'll cover some of that, to talk about the overall complexity of how to navigate this, because it is a very tricky area, as you just heard. And I want to give some kind of general thoughts about it rather than just concentrate on the science. Before I start, I should also just give my disclosures. I have done some consultancy for a number of pharma companies, as you can see on there. I don't think with anything that's directly related to what I'm going to be talking about today. And then before I start, I just wanted to kind of take a time out for a second and say that I know that many of the people listening will be parents or other relatives of children with neuroblastoma who may be going through treatment now, or maybe have gone through treatment. And when we're talking about relapse, we are talking about some very serious, stressful, complicated, and worrying topics. Not all children with neuroblastoma, of course, survive. And some of what I'll say when I talk about overall survival being this or survival being that, I just want to acknowledge that at the end of the day, we are talking about individual children. And I'm sorry that the way that sometimes things are presented scientifically doesn't reflect that. And I just want to take a moment to say that I think we should all acknowledge that the individual experience of each family going through treatment is different and important. And I hope none of this will be distressing, but apologies in advance if it is. So with that said, I just want to start for proper by talking about what do we know about the outcomes at the moment for high-risk neuroblastoma and specifically for relapse of high-risk neuroblastoma. And just to kind of take you through some of these curves. So I don't know if people on the call are familiar with these curves. They're called Kaplan-Meier curves, and they're what we use all the time in oncology to show the outcomes for patients. And I've just chosen to highlight here a recent study from Children's Oncology Group, which was a study of upfront patients with neuroblastoma, comparing giving them tandem, so 2 rounds of high-dose chemotherapy here in the orange versus 1 round of high-dose chemotherapy here in the blue. And so the curves here are event-free survival. So that means the proportion of patients surviving without a relapse, and overall survival, which means the proportion of patients surviving in total. And I just think it's important to kind of flag a few things on these curves for everyone's understanding. So first of all, these curves start, because this is a particular publication, at the end of the induction phase of chemotherapy. So this is not all patients with high-risk neuroblastoma in the first place. And so whenever you're looking at curves in publications, it's really important to know what is the starting point, because the starting point for these curves was randomization, which was only done after induction chemotherapy for patients who are going to go on to the next stage of high-dose chemotherapy. And so that means that patients who maybe had early disease progression or whose disease did not respond well to initial treatment are not included in this graph at all. So we have to be careful about that for a start. Then you can see that the curves are very steep early on and then settle out over time. And that's generally what we see, which is that the highest risk of relapse, the highest risk of an event is early on, and that's when most of them are happening. And then we get further out in time, the curve flattens out, and then we hope that it becomes completely flat, which means that there's no more events. In reality, of course, we often do see late events. And then the next thing to flag, of course, is that the curves over here on this side, the overall survival, are higher up than those on this side, the event-free survival, which means that some of these patients who have an event, which have relapse, nevertheless are surviving. They're not dying. There's some patients, unfortunately, here who are dying. And so at least initially, when patients experience a relapse, we are able to treat them and to salvage them. And then finally, the really important thing on these curves is to recognize that the way these curves work is that on the right-hand side is the longest follow-up for individual patients. And this is ultimately what most of us are interested in, is what's going to happen in the long term. But actually, often the actual number of patients whose information is feeding into the graphs on the right-hand side is very, very few. It can even be like 5 patients, 4 patients. And so you have to be very, very careful about looking at the right-hand side of these curves. The information over this side is pretty robust. The information over the right-hand side of the curves is really not. And I'm going to come back to that in a minute because it's really important. So with all of those kind of introductory words given, let's just look at this figure, which shows now the overall survival from diagnosis for all patients with high-risk neuroblastoma. And the messages are here that this is clearly improved over time. The curves have gone up, but we know that unfortunately it's by no means perfect. And if we look at around 5 years since diagnosis, you can see that the curve is roughly at 50%. And so that means that unfortunately about half of children who are diagnosed with high-risk neuroblastoma will not survive after 5 years. And that's mainly because of relapse. So some patients, the disease progresses early on. That's relatively rare. Most patients, the disease responds, but then unfortunately there is this quite high risk of the disease coming back. That's what relapse is. And then the treatment of the relapse is much more challenging. And one of the challenges is we're not actually very good at knowing what is the real outcome after relapse, because of course our treatments have changed over time. And so we don't have good long-term information because of course some of the treatments for relapse have only been introduced pretty recently. This is an analysis of international data. So this is data from North America, from Europe, from Australia, from Japan, all put together. And all of these graphs, all of these columns show groups of patients diagnosed at different times. So this is patients diagnosed in the 1980s, diagnosed in the 90s, diagnosed in 2000, and diagnosed in 2015 and onwards. And the green bar chart here is to show the actual number of patients who are having a relapse over time has gone down. And that's great news. That's because our upfront treatments have got better. And so fewer patients are experiencing a relapse in the first place. And then the blue line here is how long patients survive after their relapse. And you'll see that we're only able to look at 2-year survival just because we don't have enough data from the most recent group to do like 10-year survival or something like that. We just don't have enough follow-up time. But the reassuring thing is that the 2-year survival after relapse has dramatically increased from around 16% to around 32%. So that means that our treatments for relapse have managed over the last, what should we say, 20, 30 years, have managed to improve the survival of patients after relapse, albeit that we're only able to look at that relatively short survival time. And again, I'll come back to that in a minute. So all of that introduction leads on to some of the kind of key clinical challenges, and not just clinical, but actually challenges for families as well, in how we think about treating relapse and managing these patients. So when patients are newly diagnosed with high-risk neuroblastoma, there's essentially a pretty rigid rule book, instruction book, or menu about what to do. We do induction chemotherapy, we do surgery, we do high-dose chemotherapy, we do radiotherapy, we do immunotherapy. Some places now do DFMO after that. But the bottom line is there's a clear schedule, and there's a clear beginning, and there's a clear end when we get to the end of it and we say, okay, we've now given all of the treatment that we know is helpful to improve outcome. In relapsed neuroblastoma, it's much more complicated. And I tried to show that on this right-hand side because, first of all, there are multiple different options for how we might treat the relapse disease. There's not just one single treatment that we know is the best for all patients. It depends on side effects from previous treatments, side effects of the new treatment, what's available in different countries, what the patient is experiencing. It's a complicated decision about what the best treatment is. And what's also very complicated is that the end goal of the treatment is a lot less clear. When should we stop that relapse treatment if it's working? If a patient's disease has got back under some control, what do we do then? Do we do more treatment or can we stop treatment? Essentially, can we get back to another cure? And that is, unfortunately, a really difficult and challenging question to answer. And part of the reason why it's so challenging to answer is because we don't actually have perfect information in the relapse space. So most of the treatments that we use in upfront high-risk neuroblastoma have come about because of big, what's called phase 3 studies, where we've taken one set of treatment, compared it to another set of treatment, followed those patients for years and years and years, and said, in the long term, patients with this treatment do better than this treatment. But in the relapse setting, that's much, much harder to do because we're dealing with smaller numbers of patients. And so most studies that have happened in the relapse setting are what's called single arm. So all patients get the same treatment, and they're typically what's called phase 2. And what that means is that the major thing that we're measuring is not how long does the patient survive for, do they have a further relapse or not? It's something called objective response rate. And that really means, did the tumor respond in that patient? Did the disease shrink or did the MIBG scan get better? And so the study tells us this treatment produces this response rate in patients. But that response rate doesn't necessarily tell us how long that patient is going to do in the long, long term. There are some studies, and I'll talk about one in a minute, that are randomized where we give treatment A to some patients and treatment B to other patients. But even then, most of the time, we're still looking at this response rate endpoint rather than overall survival, which is, again, because otherwise the studies need too many patients to be practical and they run for too long for it to be feasible to give us an answer. But the problem is with the response rate is that we think that that relates to long-term outcome, but we don't actually know that for certain. And then the further complication of the studies that we have is that many studies have put together in one study patients with both relapse disease, so that's disease where the neuroblastoma has been treated successfully initially and then it has come back, with what's called refractory disease, which is quite different, which is where the disease has not responded well enough to initial treatment. And those patients need more treatment to try and get a better response. But you can imagine that those are very different patient populations, those who are going through treatment for the first time versus those who've already gone through treatment and where the disease has come back. But often they're put together in the same study. And then the final challenge is, as I mentioned earlier on, we have lots of different options for treating relapse, and I'll talk about some of those in a minute. But this question of what is our overall strategy for treating relapse is very complicated and difficult to get hold of. What should we do if a patient responds to that treatment? How many cycles of the treatment should we give? Should we carry on with it? Should we swap to something else? Should we give another high-dose chemotherapy? Should we do something called haplo? Should we do more DFMO? And those are very difficult questions to answer because there are not very many studies in that area, because it's even harder to do than a study in patients with actual relapse disease. And it's even harder to demonstrate a benefit of whatever treatment you're giving, because you can't just use response rate. You have to try and do a study that shows long-term outcome for those patients. So this is really the kind of background to why we just don't have perfect information about how best to treat relapsed neuroblastoma. And so just to give an example of this, just to pick this out because this was very recently published. So this is the European Beacon Immuno study. So this is a phase 2 trial, and it was a randomized study of adding dinutuximab beta, which is an anti-GD2 antibody, onto temozolomide-based chemotherapy in patients with relapse and refractory disease. So does adding anti-GD2 on top of the chemotherapy help to improve the response rate and the outcome? And this is the sort of key table. And you can see here, if you look at the overall response rate, so that's partial response and complete response, for the patients who did not get the antibody, it's 18%. And for patients who did get the antibody, it's 30%. So that shows us that the addition of the antibody does improve the response rate. It works better. But it still doesn't tell us how do those patients do in the long term? How many cycles of this should we use? What should we do after that? And some of this information is published in these curves here. So this is progression-free survival. So this is the proportion of patients who are free from having a further relapse. And you can see that it looks as though the curve of patients who got the dinutuximab beta, the antibody, is better than those who didn't. Although actually in the statistical analysis, this doesn't quite demonstrate statistical significance. And you can see, though, that we're still, even at the very far end of this curve, where we've probably got 3 or 4 patients, so very little information in terms of actual number of patients, we've still only got to 4 years, 48 months after starting treatment. So that still doesn't really tell us about long term. And then the overall survival, the curves look exactly the same as each other. And that's because in this study, it was further complicated, because if you progressed when you were on the arm without the antibody, then you were allowed to have treatment again, this time with the antibody. And so we were never expecting to see a difference in the overall survival. But this is just to kind of show how challenging it can be to get to the real information that we want about the longer term outcomes after relapse, because that's not what these studies are designed to show. And so in a way, this slide, I think, kind of is the heart of the conundrum about how to make decisions around treating relapse, is this balance between treatment intensity versus quality of life. When we start treatment for high-risk neuroblastoma at the very beginning, frankly, we have to tell patients a whole lot of very, very bad news about the treatment and how intensive it's going to be. But there's not much of a choice there, because we know that that's the best treatment available, and we need to give that best treatment to try and cure the patient. In the relapse setting, it's much more complicated because we don't know the best answer. And we also don't know how feasible, how possible it is to cure patients in that setting. And so some people will take an approach that says we should give the best response treatment, the most intensive early on, to try and get the maximum control of the disease as quickly as possible at the beginning. But an alternative approach, which I think is just as reasonable, is to say, actually, if a patient has got relapse disease but is very well, maybe we might want to start with a more gentle treatment approach that maybe has a less good response rate in the overall population, but might still be able to control that patient's disease, keep them out of hospital, keep them well, not experience side effects. And there, the aim is to achieve control of the disease for as long as possible. So trying to keep the disease under control for as long as possible, not trying to get as deep a response as possible. And it really depends, I think, and I think clinicians have quite a different views about this, about how realistic you think it is that an individual patient's disease is going to be curable. Because if you can cure their disease, then of course there's justification for giving very intensive treatment and then trying to get to a point where you can stop treatment. But if the disease is not going to be curable, actually an alternative approach of saying we want to maximize quality of life while still treating the disease to keep it under control might be the best approach. And the problem is, from that information I showed you earlier on, we know that about a third of patients can survive for 2 years after relapse, but we don't know what happens at 5 years, at 6 years, at 10 years. And I think our problem is that the actual proportion of patients who are able to survive in the long term is probably still lower than that 30%. And we don't at the moment know how best to identify those patients at the point of relapse. And just to kind of highlight this difficulty around decision making, this is an ex-colleague from the UK who published this sort of experience of parent treatment decision making in relapsed neuroblastoma and how complicated and difficult it is, because of course it's super stressful. There's uncertainty. That's what I've just been talking about. There's a pressure of time. There's a whole adjustment to, I thought we were dealing with long-term outcome, and now we're suddenly back into having to think about treatment. Of course, the emotions are, extreme in terms of hope for the future, but being scared about what the outcomes might be. There's this very tricky balance about what is the decision of the parent versus what is the guidance of the medical team. And especially when there's less clear of a medical answer, often we want to ask more input from the families about how they view things to try and tailor the treatment to what is right for an individual family. There's the whole issue about the logistics of treatment. It might involve traveling more to get onto a study that's only available at limited number of centers. And there's this whole real stress around decision making and multiple times for decision making. It's not just a one-off decision and then it's done. There's a lot of complicated decision making over time. So I wish I had an easy answer to this to say, well, this is the way that you would then deal with it. But what I really wanted to do was just to reflect back to families that have been through this, that we know that this is incredibly challenging and difficult. And that's why I think having some understanding of the bigger context as to why this is difficult, I hope is helpful. So let's just switch now to some of the detail about what actually are the treatments that we have and what is coming down the pipeline. And so just to give a sort of 1,000-foot view, these are sort of the headline options as the most common options for treating high-risk disease when it relapses. So cyclophosphamide topotecan is a great backbone chemotherapy for relapse. In North America, we tend to use it in induction at the very beginning as well, but we know that it can still work in relapse. And sometimes we use that on its own, and sometimes we use it to add extra agents to. So this is a drug, lorlatinib, which is an ALK inhibitor, which we'll talk about if we have time. And that has been studied in combination with chemotherapy. And there's lots of kind of combinations of new drug plus this chemo. Temozolomide irinotecan is the other kind of big backbone chemotherapy, and that's the one that most commonly has been given with anti-GD2, either that study that I just mentioned or another study that I'll mention in a minute. And in Europe, they've also tested that backbone chemotherapy with a drug called bevacizumab, which is an inhibitor of new blood vessel formation. And then the third type of treatment with the kind of best evidence behind it is this treatment called MIBG therapy, which is where we use radiation as a medicine, and the MIBG gets taken up by lots of sites of disease and can take radiation to the disease wherever it is in the body. Often quite difficult and challenging from a practicalities point of view. So those are the sort of three headline options. And really, chemoimmunotherapy, so the idea of combining chemotherapy with immunotherapy, has become the kind of default best option in a lot of the world, based on information from Europe and information from North America. So this was the COG study 1221, which originally was a very small study just comparing chemotherapy and this drug called temsirolimus with chemotherapy and dinutuximab, which is another anti-GD2 antibody. And the response rate for partial responses, you can see here, and complete responses, was much, much better in those patients who got the antibody. And this was a really small number of patients. And so the study went on to a larger group of patients and confirmed that response rate of about 50% in patients with relapse disease. So that has then created a lot of excitement about that really being a good way to treat relapse disease, because response in 50% of patients is actually pretty good. Of course, the obvious question is, well, what about the other 50% of patients whose disease does not respond to that treatment? And that is definitely a challenge. And then, and then over on this side, I've just put the Beacon Immuno study that we already just spoke about, where they compared slightly different chemotherapy with and without the addition of dinutuximab beta, which is another anti-GD2 antibody. And so now that we are sort of familiar with chemoimmunotherapy as being a good treatment for relapse disease, there's a lot of work going on to say, well, what could we add to that treatment to see if there's a way of making it better? And one study that was recently completed, and the results were just presented at a meeting last year, was to add on to this backbone of temozolomide or irinotecan and anti-GD2, a medicine called DFMO. So DFMO, that many people have heard about, is now approved in the US and in a few other jurisdictions to be given to patients with high-risk neuroblastoma at the end of their treatment, with the idea of preventing it from coming back. And it's a medicine that blocks this enzyme called ODC1. And there were multiple lines of evidence to suggest that maybe we could add that onto this backbone of chemoimmunotherapy and see if it was effective. So this study was done actually with a much higher dose of DFMO than is normally used in the maintenance setting. And unfortunately, the results showed that actually there was not an improvement in the response rate. So this is the overall response rate in the control arm, about 50%, and the overall response rate in the arm with the DFMO, in addition to the chemoimmuno, again around 50%. So this, was an important study, but unfortunately didn't actually show a benefit of the DFMO. Lots of other things still under consideration. So in Europe, the Beacon study has gone on now into a second iteration called Beacon 2. And so one part of that study is comparing chemo with bevacizumab, which is this drug that blocks new blood vessel formation, with chemo plus anti-GD2 to see which of those is better. And then there's another arm of the study where they're testing the combination of all four of those, so temozolomide, irinotecan, and the bevacizumab, which blocks the blood vessels, and the anti-GD2, to see if A, that is safe, and then to take that forward to see whether maybe it might be more effective than just those combinations of three. There's preclinical work that has gone on. So this is in a lab. Looking again, you can see temozolomide, irinotecan, dinutuximab, and then two extra medicines. These are called anti-TIGIT and anti-PD-L1. So these are what's called immune checkpoint inhibitors, which is this idea that the immune system is very tightly controlled in the body so that it's not overactive and also it's not underactive. But maybe we could boost the immune system to make it more active against the tumor by blocking some of these molecules that tell the immune system to turn down. And so this is a study in a lab where you can see if you give mice with a neuroblastoma tumor treatment with temozolomide, irinotecan, anti-GD2, and the anti-TIGIT, and the anti-PD-L1, which is in the purple here, you are able to actually cure some of these mice from their neuroblastoma. And so we're just working at the moment in the NANT group to try and convert this into a trial so that we can test this in patients. Another study that's in preparation is through the Children's Oncology Group, which is to use a new medicine called a cereblon, which is quite a complicated type of molecule, but essentially for the purposes of this discussion, it acts as a immune modulator. So it's another way of adjusting and changing the immune system with the idea of ramping it up and making the effect of this chemoimmunotherapy against the neuroblastoma stronger. And so this study is going to test actually a slightly different chemo. So you see here the cyclophosphamide topotecan rather than temozolomide or irinotecan, again with dinutuximab, and then with the addition of this new drug to try and stimulate the immune system further. So quite a lot of work building on the chemoimmunotherapy to try and make it a stronger type of treatment to try and enhance that immune response. And there's been lots of other studies, and either completed or in development or ongoing, about other immunotherapy approaches. So one of these was a study that unfortunately closed early because the drug was discontinued because it didn't work in adults. But this was the idea of giving anti-GD2 together with a different immune checkpoint. So this time one that activates macrophages. So macrophages are a cell in your body, in your immune system, that are designed to kind of eat up waste cells. And so the idea here was to activate those macrophages in addition to labeling the neuroblastoma with the anti-GD2, and then to get those macrophages to eat those tumor cells. And so unfortunately that study had to close early, as I said, but there's still lots of work going on with other similar molecules in the lab. And then a study which is just getting underway now at St. Jude and will open at a few other hospitals in the US is again using anti-GD2 and chemotherapy. And this time another new drug called N803, which is what's called an IL-15 superagonist. So superagonist means something that really stimulates something very hard. And IL-15 is what's called a cytokine. So that's a molecule that stimulates cells in the immune system. So this is a very similar theme, this idea of taking what we've got that we know works, chemoimmunotherapy, and then trying to ramp it up to make it work more strongly by giving drugs that stimulate the patient's immune system. And so this study, as I say, is just getting underway now based on data in mice to show that it's helpful. And we're now trying to study whether it's going to be helpful in patients with neuroblastoma. Another way of using immunotherapy is rather than using antibodies to directly try and kill or label the cells, is to use antibodies to take a drug to the cancer cells. So normally when we give a chemotherapy drug, we give it into the bloodstream and it floats around everywhere in the bloodstream, and we hope that some of it goes to the tumor. With this technology called an antibody drug conjugate, we stick a special chemotherapy onto an antibody in the lab, and then we give this to the patient, and the antibody then recognizes the tumor cells and gets taken up into the tumor cells. And that means that the chemotherapy then gets into the tumor cells. So we think that it's a way of targeting the chemotherapy better to the tumor cells. This has been very successful in lots of adult cancers, especially breast cancer. And we're just at the beginning of testing this now in pediatrics. So there's some studies going on right now from Merck with two different antibody drug conjugates. These are just the names of their targets. And at CHOP, so this is in Philadelphia, they're working on another antibody drug conjugate to target ALK that we know is another molecule that is expressed on a lot of neuroblastoma cells. And you can just see here some of their preclinical data. So this is mice, not patients, showing that if you treat these mice with tumors either with salty water, then the tumors just grow. But if you treat them with this new antibody drug conjugate, then you can really delay the growth of that tumor, and the mice have much longer survival time. So I think there's a lot of promise for these types of drugs for the future, but we're just at the very beginning of testing them in children now. And then, of course, no talk about relapse could be complete without talking about CAR T cells. And I know that's been covered quite a lot on previous meetings. And we actually had Francesca Del Buffalo on the last call talking about this study that I'll just highlight, which is from the Rome group using an anti-GD2 CAR. So this is when we genetically engineer the patient's own T cells to retarget them, to redirect them against the neuroblastoma, and then infuse them back. And I think this is a super exciting technology. We're still really at a pretty early stage for this. This paper got a lot of attention because it's sort of the best results we've seen so far, but we're still trying to work out the best way of using this And there's a lot of work going on to develop different CARs, different ways of using the constructs, and of course, a lot of different targets that we could think about making CARs against. So I've already mentioned GD2. And so there's that study from Rome. There's a study going on at the moment from the National Cancer Institute in the US, and then also studies at Baylor and 2 studies going on at CHOP in the US in Philadelphia. Again, you can see with different targets. But I think the important thing to say is that all of these are at a pretty early stage of development. They're all in what's called phase 1 studies, which is where we're trying to work out about the safety, the dose, the toxicity. These are not yet therapies that we know work and are in a position to recommend by any means as a routine part of treatment, but very exciting for the future. And then what else is there in terms of cellular therapy? So we can use different cells, not just CAR T cells. There's also another group of cells called NK cells, called natural killer cells, which are in the body naturally, and we think are very important for eating up, for killing neuroblastoma cells when they're labeled with the anti-GD2 antibody. And so a couple of studies that have happened and are running now through NANT. So one study, which is where NK cells were taken from an individual patient and expanded in the lab. And then actually quite excitingly, a new study that's happening at the moment with what's called allogeneic donor. So that means from another person, from a volunteer donor, so that the NK cells can be grown up in the lab and then almost made available as a medicine. And you can see, again, that's being given in combination with anti-GD2 chemoimmunotherapy. So again, the idea, chemoimmunotherapy plus something else to try and make it work better in terms of an immune response. A brief word, changing gear from immunotherapy, about molecular radiotherapy. So I've already mentioned MIBG therapy, and this is just to kind of highlight the series of studies that have been done most recently. So most recently, there was a study that said, if MIBG therapy on its own is good, what about combining it with something else? And so there was a randomized study that showed if you combined it with this drug called vorinostat, which is a chemotherapy that we very rarely use in neuroblastoma on its own, but it's shown that it can make the neuroblastoma cells more sensitive to radiation, that appears to improve the response rate. And then a further study was done saying, what about giving MIBG with anti-GD2? And that was shown to be safe. And then the study added vorinostat into that as well. So vorinostat, anti-GD2, and MIBG, and showed some very interesting responses. And so there is a plan, as I'll talk about in a second, to go on and do a randomized study to see which of those combinations is better. And then a study from Europe and also open in Wisconsin has been MIBG together with dinutuximab beta, so another anti-GD2 antibody, together with nivolumab, which is an immune checkpoint inhibitor like the one I mentioned earlier. So again, to try and ramp up the immune system. So there are some further studies going on. NANT are in the process of trying to open a randomized study with MIBG to see which of these extra drugs is the most effective. UK and various other sites, including us in Toronto, are in the process of working on a study to combine MIBG with this drug called talazoparib, which is another targeted medicine. And then there are also lots of other what's called radiopharmaceuticals, so other medicines that work as radiotherapy that are in the pipeline and in development. And so in the final minutes, I just want to take a brief second to talk about cancer biology, because I think it's becoming increasingly clear that we would love to be able to tailor our treatment for neuroblastoma to each individual particular patient, and that there is some use, therefore, in looking at the tumor genetics, not just at diagnosis, but also, again, at relapse. So this is to talk about ALK, which many of you will have heard of because we're very excited about that being a target in neuroblastoma. And this is just to say that we know that patients whose tumors have ALK changes, so that's an ALK mutation or an ALK amplification, generally have a worse outcome than if you don't have an ALK mutation. And that's why lots of groups are now testing adding ALK inhibitors into upfront treatment. Importantly, we know that the rate of ALK mutations can significantly increase at relapse. And so it's worth thinking about, is it possible to rebiopsy this tumor at relapse? Is it possible to look at ctDNA to look for an ALK mutation, even if there wasn't one there, a diagnosis? Because there are effective drugs. And so this is a study from NANT with this ALK inhibitor I mentioned earlier on called lorlatinib, given in combination with chemotherapy are altered in cyclophosphamide and topotecan. And the details of here don't really matter, but essentially this did show some really pretty good response rates in patients with relapse disease, as long as there was that ALK mutation present. So with an ALK mutation, this ALK inhibitor in combination with chemotherapy can be pretty successful in helping to control the disease. You can see a response rate there for the combination of chemotherapy and the ALK inhibitor of around 60%. Many other molecularly targeted drugs are under evaluation or have been studied, and I've just listed a few of them here. What's challenging is that for a lot of these, we don't actually know the best way to select patients. So we have a drug that targets a particular pathway in cancer cells in general, but we don't know how best to pick the patients who will respond to those drugs. On the other hand, we know that there are also clear targets in neuroblastoma, MYC amplification that everyone will have heard of, but also something else called telomerase and this thing called ALT, which stands for alternative lengthening of telomeres, but it's basically another way that cancer cells learn to survive. And we've known that those two things are very important for neuroblastoma for many, many years, but we don't have good drugs to target any of those genes at the moment. So we're in a little bit of a conundrum of having some drugs where we don't quite know how to select the patients, other patients that we know have got something that we should be able to target, but we can't yet work out how best to target it. And so I think ALK remains a key target, and there's clear rationale for sequencing, but we still don't quite know how to use a lot of the other molecular findings that we might get at relapse. So in the final moments, just to wrap up, I want to leave with a few thoughts. So one is, I think it's reassuring that even with our improvements in upfront treatment for high-risk neuroblastoma, we have still managed to improve the outcome for patients with relapse neuroblastoma. So we are making progress both in upfront and in relapse. And I think that argues for the benefits of giving intensive active treatment in relapse disease. Navigating what to do is very challenging because there are lots of different options, and people's heads are probably spinning from everything that I've run through in this quick talk. It's very complicated how to make decisions. Options vary depending on patients and location. What's right for one might not be right for another. And this challenge of whether we can cure patients really remains very, very challenging and difficult to manage. As I've spoken about, chemoimmunotherapy has become one of the major backbones for treating relapse, and we're trying to add to that to make it work better. But we're also now in the process of testing chemoimmunotherapy in the upfront setting for new patients with high-risk neuroblastoma. And so that may have implications in 5 or 10 years' time for how we treat relapse, and we don't know how to manage that yet. We've spoken about molecular targets, but as I've highlighted, there are many targets that we still don't have good drugs for, and so getting access to those new drugs is still going to be really important. So I just want to finish by acknowledging everyone in the neuroblastoma community, because this work is all theirs. I've put the logos of the different consortia on there, and of course, all the patients and families who've participated in the studies, and to thank all of you for listening. And I'm very happy to take any questions from anyone who's online. You should be able to see on your screen a Q&A button, question and answer button, and you can put questions in there, and I will do my best to answer them. So I'm going to stop sharing. I'm going to go across to the Q&A, and I'll see what I can do in terms of answering these. Okay, so first question. Do you know why relapse occurs, especially in the setting where children are getting multiple relapses and able to get complete remission? That experience seems to suggest it isn't disease that survived the treatment. So what possible mechanisms could be at work? So that is a great question. So we really believe that relapse in the vast, vast majority of patients is occurring because some cancer cells have managed to survive through all of the treatment that patient has received, and then managed to regrow. So we think getting a brand new neuroblastoma is incredibly unlikely and incredibly rare, except for very few patients that may have a particular genetic reason to get neuroblastoma. So for most patients, I think what happens is that our scans are just not sensitive enough to tell us, have we completely got rid of this cancer so that there are no cells left? Or have we got rid of it 99.9% such that we can't see anything on a scan, but there are still cancer cells somewhere detectable? And we're beginning to get a little bit of a hint of that through something called ctDNA, which is where we can detect small amounts of DNA in the blood. And it might be that in the future, we are able to have assays which are called MRD, minimal residual disease assays, where we can detect a very small amount of disease, smaller than we can see on a scan. And it might be that we can then say, that patient looks as though they're completely in remission, but actually they're not, because we can still see a tiny little bit of disease on their blood test. And then maybe there's extra treatment that we can give them. So I think even for patients who are getting multiple relapses, our thought is that even if we get into a complete response on a scan, we probably still haven't got completely rid of all of the chemotherapy, all of the neuroblastoma cells. Next question. For relapse cyclotopo, are the doses high as the dose used in induction? I believe the IT dose used in relapse is lower than the induction dose. So it depends, it varies a little bit from center to center about exactly the doses that are given. The doses we use here, which were based on the original studies that were done for cyclophosphamide topotecan in relapse, do use a lower dose than in induction, generally because, of course, patients by the time they experience relapse have been through a lot of treatment up front and have also had high-dose chemotherapy and stem cell rescue, and generally can't tolerate as high a dose of chemotherapy. And so we normally start with a lower dose, and actually quite often we have to either give an extra week for the blood counts to recover, so we give the chemotherapy every 4 weeks rather than every 3 weeks. And we sometimes have to reduce the dose down even further. So rather than giving 5 days, we give 4 days, or we give 3 days. And so generally, yes, we use a lower dose. I think what's also challenging is that we're still not entirely clear how much the dose matters. And in a way, it gets back a little bit to that argument I made earlier on in the talk between giving as much as you possibly can in terms of dose as a hard hit for maybe a few cycles, versus on the other hand, it's probably better in the relapse setting to have something that can be tolerated over multiple cycles, because actually you want to have something that can continue to control the disease over a long period of time. And a few years back, my colleagues here at SickKids published the experience of giving cyclophosphamide topotecan and actually showed that some patients are able to tolerate more than a year of that treatment if you get the doses right. Another question, what are your thoughts on wrist? So that's also an excellent question, and apologies that I didn't include that in my talk. That was an oversight. So for those people who've not familiar with that, this is a study that the German group did and recently published. So the I and the T in wrist stand for irinotecan temozolomide. So it's the same chemotherapy as we've been talking about. And then the R and the S stand for two other drugs called rapamycin and Sprycel, which is also known as dasatinib. So these are two targeted drugs that target different pathways in cancer cells that are then being given in combination with the chemotherapy. So this is not chemoimmunotherapy, it's chemo plus targeted therapy. And that study showed that actually comparing giving the wrist, so all 4 drugs against the 2 drugs, did not improve the overall response rate for patients with high-risk neuroblastoma in relapse. But what was very interesting is that if you just looked at patients with MYC amplified relapse disease, it did seem to have an improved effect. So it does look as though for patients with relapse MYC amplified disease, so only those with MYC amplified disease, that adding the rapamycin and the dasatinib to the chemotherapy does improve the response rate. Problem is, what we don't know is quite how that works. And also we don't know, is that better than chemo and immunotherapy? And of course, the obvious question is, what about chemo, immunotherapy, and those targeted agents together? And as far as I know, that study hasn't been done yet. So absolutely a great suggestion. I should have included that in the talk, that it's yet another thing on the list of options available for treating relapse disease. I think at the moment, the evidence is best for patients with MYC amplified disease only. Another question. Are you familiar with the ALK CAR T-cell trial at Boston Children and the results from that so far? So I have to make a confession and say the simple answer is no. I actually have not come across that study. So when this goes out on the recording, apologies to the investigators of that study, but I'm not familiar with it at the moment. But as soon as this talk is finished, I'm going to go and look that up so that I am familiar with it next time. Apologies. And then someone has asked an excellent question about similitisertib, which I must confess also not quite sure exactly what that is. So I'm going to look that up very quickly. So that is a targeted drug against a protein kinase called CK2. So I will have to admit to whoever put that question in that I have not come across that drug explicitly. It looks to me as though it's a drug that is still in very early development. And I'm not aware of any studies of that in neuroblastoma specifically, but I'm going to take a screenshot of these because I'm going to go and look them up after we finish talking. Another question. As more high-risk patients are surviving longer, is there any drive to have a more comprehensive survivorship initiative among COG and international organizations to better track these patients and long-term survivorship late effects? And my daughter had multiple lesions and there's no clear data on how to follow her. Yeah, so survivorship, I must confess, is not my area of expertise, but I think it's a really important issue that we know that, yes, patients with high-risk neuroblastoma are now surviving. And although relapse, unfortunately, is still too common, equally, there are patients who are cured of their neuroblastoma and for whom the neuroblastoma will never come back. And that is a great success, but it does have to be set against the very intensive treatment that we put those patients through: chemo, radiotherapy, high-dose chemotherapy, immunotherapy, et cetera, et cetera. And so I think, the answer is there is a drive to have more comprehensive survivorship, and there are a lot of initiatives going on. So some of those initiatives are research. So the COG recently did a study called LEARN, LEARN with an H in it, which was to collect a cohort, a group of patients who were 5-year survivors of high-risk neuroblastoma, and to look at what sort of side effects, what sort of medical issues those patients were dealing with 5 years after the end of treatment. And that produced some very important data about the impacts of our treatment on hearing, kidney, growth, schooling, education, all of that sort of thing. And there's now plans for another study, I believe, to track those patients over a longer period of time, and also to collect another cohort of patients. Because, of course, the challenge is that follow-up on patients now who are 10 years after the end of treatment was on treatment that they received 10 or more years ago. And the treatment we're giving now is different from the treatment 10 years ago, which is different from the treatment 20 years ago. So this is inevitably an ongoing effort that has to continue, because as we change our treatment, it's quite likely that the late effects will change. And then beyond research, I know that there's also a lot of work going on, especially in Europe, I think, about having a sort of passport system to standardize the information that is given to patients at the end of treatment, so that they have that information about what the risks were, what their exposures were, and what the potential complications that they may have over time. So I do think it's certainly a very important area, and clearly there's a need for people with specialist knowledge about exactly what patients have been through and the implications for their future health, because we know that there are a whole range of very common consequences, as well as some much rarer consequences like the ones that you've mentioned in your question. No question, but thank you for sending that. And then a question about suggestions for refractory disease. So refractory disease is kind of a whole nother topic that we didn't get into a lot here. So for refractory disease, what we're talking about is patients with high-risk neuroblastoma whose disease has not responded as well as we want it to initial induction chemotherapy. And so what we think is that those patients will benefit from additional bridge or salvage treatment to try and get better control of their disease, probably with the aim of then looping back to their original treatment. And we don't know for certain what the best treatment is in that situation. Most of us, in North America at least, would use chemo immunotherapy again in that situation. But there are also other things that could be used like MIBG therapy. And what we don't know for certain is how many cycles of that salvage treatment to give and whether and when to loop back around to the original treatment with high dose chemotherapy. So I think some of it depends on the individual situation. And the other bit that's very complicated, there's no single global definition of refractory disease, because really it comes down to a question clinically of, is this response good enough for us to proceed to high dose chemotherapy? And if the answer is no, that effectively counts as refractory disease. But the rules, as it were, for proceeding to high dose chemotherapy are a bit different between COG and SIOPEN for patients on study, and therefore a little bit different between institutions and clinicians as well. And so sometimes it comes down to sort of individual patient decision. Okay, in the closing second, final question I think we've just got time for. In terms of risk classification, I meant to say ultra high risk category patients. Is there new learning from ultra high? Yeah. So this is about, can we identify ultra high risk patients from the beginning? And I think this is a really important but challenging question. So at the moment, most patients with high risk neuroblastoma are treated in largely the same way, with that induction chemotherapy, surgery, high-dose chemotherapy, radiotherapy, immunotherapy. In fact, we have already begun to change it a little bit, because patients with ALK mutations might be eligible for a study testing an ALK inhibitor as well as that chemotherapy. Some patients with high-risk disease will not be eligible for the current high-risk study that increases the intensity of treatment. So by that, I mean that there are some patients with high-risk disease, either because they're infants or because they are older patients with localized disease that's not MEK amplified. And for those patients, we would treat as high risk, but we might not, for instance, give them a tandem high-dose chemotherapy. What we're not very good at is identifying the patients with ultra high risk. So those are patients whose, from diagnosis, are going to have a challenging time with treatment and not respond well to treatment. Part of the problem is that at the moment, we don't have a single way of identifying them. There are factors that make you higher risk or lower risk, but they're not strong enough to say it's not worth giving you X or Y. And the other real problem is we don't have at the moment a great treatment for neuroblastoma that we're keeping in reserve for those ultra high risk patients. At the moment, for patients with high risk neuroblastoma, we're already giving the best treatments that we know of: the chemotherapy, the chemoimmuno, potentially the high dose chemotherapy, the radiotherapy, immunotherapy, blah, 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 blah. And so even if we had a way of identifying ultra high risk patients at the beginning, it's still not clear how we would actually use that information in practice. Would we say, this is hopeless, there's no point in being treated? Maybe, but then we'd have to be really very, very, very sure that we were able to correctly identify that group of patients, and we're really not there at the moment. So I think it's a really important question, but we're not quite there at the moment. And I think actually the same question applies in the relapse population, that it would be ideal if we could find out of those patients who have a relapse, who are those who are going to be cured and who are those who unfortunately we are less likely to be able to cure. But again, at the moment, we don't have a perfect way of doing that. So looking at the clock, I think we're just about at the end of the hour. Thank you so much, everyone, for your questions. Apologies for those two questions I didn't know the answer to, but I'm going to go and do my studying now. And I'll hand it back to Inat to wrap up.
Thank you so much, Dr. Morgenstern. You're amazing for this amazing talk, for your time, for your insights and compassion, your ability to speak honestly about relapse while highlighting the progress, innovation, and collaboration gives families something deeply important, which is understanding and hope. To all of you who joined us, thank you. Your presence, your questions, and your willingness to engage these difficult conversations are what makes this community strong. No one should have to face neuroblastoma alone. As we continue this series, we invite you to join us to the next webinar where Dr. Rob Bagatelle, the chair of COG Neuroblastoma Committee, will provide an update on the COG clinical trial. We hope you'll continue learning with us, asking questions, and staying connected. Until next time, take care, stay informed, and remember, together we can change the future of children with neuroblastoma. Thank you so much, and enjoy the rest of the day.